In the next section, we will discuss the topic of renal blood flow. The kidneys receive about 25% of the cardiac output. This is among the highest of all organ systems. In a person whose cardiac output is 5 liters per minute, a normal range, renal blood flow, referred to as RBF, is 1.25 liters per minute, or approximately 1,800 liters per day. Such high rates of renal blood flow are not surprising in light of the central role the kidneys play in maintaining the volume and composition of the body fluids. We will refer to Table 6-5. Table 6-5 refers to the renal vasoconstrictors and vasodilators. This is found on page 247 of the text. You can see the predominant vasoconstrictors are the sympathetic nerves via catecholamines, angiotensin II, and endothelin. The predominant vasodilators are the prostaglandins, both PGE2 and PGI2, nitric oxide, bradykinin, and dopamine. As with any blood flow, renal blood flow is directly proportional to the pressure gradient between the renal artery and the renal vein, and is inversely proportional to the resistance of the renal vasculature. Recall from Chapter 4 that flow is equal to the change in pressure over the resistance. Recall also that the resistance is provided mainly by the arterioles. The kidneys are unusual, however, in that there are two sets of arterioles, the afferent and the efferent. The major mechanism for changing blood flow is by changing arteriolar resistance. In the kidney, this can be accomplished by changing afferent arteriolar resistance and/or efferent arteriolar resistance. Once again, Table 6-5 identifies the major vasoconstrictors and vasodilators by which afferent or efferent arterial resistance is changed. First, we'll discuss the role of the sympathetic nervous system and circulating catecholamines. Both afferent and efferent arterioles are innervated by sympathetic nerve fibers that produce vasoconstriction by activating alpha-1 receptors. However, because there are far more alpha-1 receptors on the afferent arterioles, increased sympathetic nerve activity causes a decrease in both renal blood flow and GFR. The effects of the sympathetic nervous system on renal vascular resistance can be appreciated by considering the responses to severe hemorrhage. Recall from Chapter 4 that blood loss and the resulting decrease in arterial pressure causes, via the baroreceptor mechanism, an increase in sympathetic outflow to the heart and blood vessels. When renal alpha-1 receptors are activated by this increase in sympathetic activity, there is vasoconstriction of afferent arterioles that leads to a decrease in renal blood flow and glomerular filtration rate. Thus, the cardiovascular system will attempt to raise arterial pressure even at the expense of blood flow to the kidneys. Angiotensin II also plays a role as a potent vasoconstrictor of both afferent and efferent arterioles. The effect of angiotensin on renal blood flow is clear. It constricts both sets of arterioles, increases resistance, and decreases blood flow. However, the efferent arteriole is much more sensitive to angiotensin II than the afferent arteriole. This difference in sensitivity has consequences for its effect on glomerular filtration rate. We will go into more detail when we discuss its regulation of GFR. Briefly, however, low levels of angiotensin II produce an increase in GFR by selectively constricting the efferent arterioles. High levels of angiotensin II produce a decrease in GFR by constricting both afferent and efferent arterioles. In hemorrhage, blood loss leads to decreased arterial blood pressure. This activates the renin-angiotensin-aldosterone system. The high level of angiotensin II, together with the increased sympathetic nerve activity, constricts afferent and efferent arterioles, causing a decrease in renal blood flow and glomerular filtration rate. The prostaglandins play a vasodilatory role in renal blood flow. Several prostaglandins, such as PGE2 and PGI2, are produced locally in the kidneys and cause vasodilatation of both the afferent and the efferent arterioles. The same stimuli that activate the sympathetic nervous system and increase angiotensin II levels in hemorrhage also activate local renal prostaglandin production. Although these actions may seem contradictory, the vasodilatory effects of prostaglandins are clearly protective for renal blood flow. Thus, prostaglandins modulate the vasoconstriction produced by the sympathetic nervous system and angiotensin II. Unopposed, this vasoconstriction can cause a profound reduction in renal blood flow, resulting in renal failure. Nonsteroidal anti-inflammatory drugs, or NSAIDs, inhibit the synthesis of prostaglandins and therefore interfere with the protective effects of prostaglandins on renal function following a hemorrhage. This is why, in clinical experience, nonsteroidals have usually little effect on renal function. However, in the setting of volume depletion or falls in effective circulating volume, continued use of nonsteroidals can lead to a rapid decline in renal function. Dopamine, a precursor of norepinephrine, has selective actions on arterioles in several vascular beds. At low levels, dopamine dilates cerebral, cardiac, splanchnic, and renal arterioles and constricts skeletal muscle and cutaneous arterioles. Thus, in theory, a low dosage of dopamine can be administered in the treatment of hemorrhage because of its protective or vasodilatory effect on blood flow in severe critical organs, including the kidneys. Unfortunately, this has not panned out in clinical experience, and low-dose dopamine for renal protection is no longer routinely used. We will next discuss the concept of autoregulation as it applies to regulation of renal blood flow. We will refer you to Figure 6-6 on page 248 of the text. Renal blood flow is autoregulated over a wide range of mean arterial pressures. Renal arterial pressure can vary from 80 to 200 millimeters of mercury, yet renal blood flow will be kept constant. Only when renal arterial pressure decreases to less than 80 millimeters of mercury does renal blood flow also decrease. The only way to maintain this constancy of blood flow in the face of changing arterial pressure is by varying the resistance of the arterioles. Thus, as renal arterial pressure increases or decreases, renal resistance must increase or decrease proportionally. If you recall, flow is determined by the change in pressure over the resistance. For renal autoregulation, it is believed that the resistance is controlled primarily at the level of the afferent arteriole rather than the efferent arteriole. The mechanism of autoregulation is not completely understood, but is thought to include the effects of various calcium channels. Clearly, the autonomic nervous system is not involved, since a denervated kidney, such as a kidney transplant, autoregulates